We're now going to cover hypersensitivity and immunodeficiency. So most of our immune reactions are positive things. They attack organisms or mutated cells, and they mediate healing. The immune disorder includes hypersensitivity and allergy, transplant immunopathology or rejection, autoimmune diseases, and immune deficiency disorders. What is hypersensitivity? Well, it's an altered immunological reaction to an antigen, a foreign substance. It's a state of altered reactivity, and it's an exaggerated immune response to what is perceived as a foreign or harmful substance, an antigen. So you can see this little kitty here in the corner. So some people may have an allergy or a hypersensitivity reaction to maybe the fur or the dander on an animal. So there are a couple different classifications for hypersensitivity. It's classified by source: allergy, autoimmune, or alloimmune. We also classify it by the mechanism of reaction. So a type 1 is IgE mediated. So remember, IgE, allergy. So think of those allergic reactions. It's involving the IgE immunoglobulin. Type 2 is tissue specific, and it is antibody mediated. Type 3 is immune complex, so that's an antigen and antibody coming together, immune complex mediated. And type 4 is cell mediated, meaning it's involving the T lymphocytes. So let's look more in depth on type 1, or IgE allergy mediated. This includes most allergic reactions people have, and it's an excessive reaction to foreign antigens that are inhaled, ingested, or even just touched. This could include pollens, mold, fungi, animal dander, food. Type 1 reactions can begin rapidly. They can range from just annoying to life-threatening anaphylaxis. The immune components that are involved include the T helper cell 2, IgE, mast cells that degranulate and release histamine, and leukocytes. So the T helper 2 cells recognize the allergen, and plasma cells produce IgE antibody to that allergen. The mast cells then get sensitized by those IgE antibodies because they attach to the receptors on the mast cells, leading to degranulation and release of histamine. Subsequent exposures to that antigen can lead to the antigen attaching to antibodies on the mast cell. Mast cells can activate releasing histamine and chemotactic factors such as prostaglandin and leukotrienes. Mast cells are activated and can release histamine and chemotactic factors, as well as prostaglandin and leukotrienes. So there's two phases of a type 1 reaction. There's that primary or early phase, which is within 5 to 30 minutes. There's this release of histamine and those chemotactic factors from that mast cell. Then there's that secondary or late response, which can happen 2 to 8 hours later. And this goes through the arachidonic acid pathway that leads to the prostaglandin and leukotriene release. This is also when the leukocyte and eosinophil infiltration will occur. So the symptoms are going to differ here. Our primary early response is going to involve vasodilation, vascular permeability with swelling, and smooth muscle spasm. Over here, we have the late response, where there's going to be mucosal edema, swelling in the lips, mucus secretion, leukocyte infiltration, epithelial damage, and bronchospasm. Moving on to type 2. This is antibody mediated. Antibodies mistakenly attach to the person's own cells, which cause destruction of those cells. So why do antibodies mistakenly bind to their own cells? Well, cells have a tissue-specific antigen that, for some reason, are mistaken as targets by our antibodies. So this could be platelets, red blood cells, beta cells, thyroid cells. Medications or chemicals may bind to the body's own antigens, which change them, making them become a target for our immune system. So how does destruction occur in type 2? Well, there's damage that occurs because of the complement system. We have phagocytosis that occurs by macrophages and neutrophils that come in. Then we also have those natural killer cells that come in because of those antibodies, and they will kill those cells that they think are infected. So here is a complement-mediated lysis. So the antibodies attach to the red blood cell, and complement system gets activated to destroy the red blood cell. This one, a red blood cell, has been tagged by antibody, and it's attracted a phagocyte that will come and destroy that red blood cell. This antibody attracted a cytotoxic T cell, which killed the red blood cell. And this cell has a receptor that was blocked here. This diagram shows another way that the cells can get damaged or tissues. We have antigens that will deposit into the tissue itself. So then the antibody is going to come and bind to those antigens that are deposited in the tissue, which is going to activate the complement system, which is going to attract those other cells over, those white blood cells. So we have neutrophil chemotaxis that comes along, and they see this antibody tagging or opsonizing these antigens that are embedded in the tissue. This white blood cell is going to start destroying and engulfing the antibody, antigen, as well as the tissue in the area. And that's going to release enzymes that's going to be destructive, as well as reactive oxygen species that will also be destructive to the tissue. These antibodies can also contribute to cell dysfunction rather than destruction. It's going to lead to a change in the cell function. So an example that we can use is an autoantibody against the thyroid stimulating hormone receptors. This is interesting because it will actually go, the antibody will go to the thyroid stimulating receptor on our thyroid cell, and the receptor thinks, oh, this is thyroid stimulating hormone, and it will cause an increased release of thyroid hormone. So this person will have hyperthyroidism, also known as Graves' disease. So it didn't destroy the cell, but it altered the function. Another example could be the blockage of the acetylcholine receptors in a disease such as myasthenia gravis. So we have this receptor on the muscle, and we have a nerve ending that's supposed to be releasing acetylcholine, and it's supposed to go to these receptors in the muscle to make movement, but instead it's getting blocked by these antibodies at these receptors. So that's going to affect movement at the neuromuscular junction. Type 3 is immune complex mediated. So it's not just an antigen or just an antibody. It is both an antigen and an antibody that come together and bind and form a complex, and they're floating around in the circulation, and then they get deposited in tissue or blood vessels. This will activate complement system yet again, causing inflammation and attraction of those neutrophils to the area, and that'll lead to destruction of that healthy tissue once again with enzymes and reactive oxygen species. Some examples of a type 3 reaction could be immune complex deposits in blood vessels causing vasculitis, which is seen in patients that have systemic lupus. You can also have deposits of antibody antigen complexes in the glomerulus of the kidney, leading to acute glomerular nephritis. So inflammation in the nephrons of the glomeruli of the kidney resulting in kidney damage. There's also joint synovium, which leads to rheumatoid arthritis. There's also the arthritis reaction, which is local tissue necrosis that occurs from an allergic reaction. Serum sickness is a systemic problem where immune complexes deposit in multiple locations, including the blood, vessels, joints, heart, and kidney. And the last hypersensitivity reaction is type 4, which is cell-mediated. This means it involves T lymphocytes. There's two types. There's the direct cell-mediated cytotoxic T cells, or the delayed hypersensitivity involving helper T cells. Some examples include a TB skin test, contact dermatitis through maybe poison ivy, poison oak, a nickel allergy, and it plays a role in Hashimoto's thyroiditis disease, as well as rheumatoid arthritis and type 1 diabetes. So here we have a targeted cell that has a T cell that is coming and destroying that cell for apoptosis, or a T helper cell that is coming, attracting a macrophage to the area to destroy that cell. So allergic reactions. Type 1 is the most common, IgE, allergy, followed by type 4. Type 2 and 3 are rare, but signs and symptoms of allergic reactions include itching, swelling or edema, urticaria and hives, bronchospasm, so tightening of the airway, smooth muscle contraction, difficulty breathing and wheezing. The GI symptoms, you can have cramping, nausea, and vomiting. And then a systemic whole body wide reaction can include anaphylaxis. People who have allergic reactions may have a genetic predisposition, so these patients may be atopic, which means they may produce more IgE and have more Fc fragment crystalline receptors on their mast cells. Now, when somebody has an organ transplant or tissues or cells transferred from one individual to another, these tissues are called grafts. An individual who receives it is called a host or a recipient. Now, the host tissue has those MHC class 1 antigens on it, and it will determine if something's rejected. Now, if somebody gets a donation from another person or a donor, that's allogenic. It's syngenic if it's from identical twins. Autologous is if the donation is coming from one's own self. Rejection occurs when the immune system attacks that graft. Rejection of those transplanted cells or tissue by the recipient's immune system can occur. T cells and antibodies may be involved. The types include hyperacute, which means they have a pre-existing antibody to it. Acute, which is a type 4 reaction. Chronic, which is a type 4 and a type 2. And you could have a graft versus host disease, where there's rejection of the body, usually by transplanted bone marrow. It is possible with liver transplant. This is a T cell reaction. Now, autoimmune diseases are often complex disorders which do not have a single source. So there's going to be a reaction to self-antigens. We somehow lose a tolerance of ourself. There's some kind of defect or error in the mechanisms that eliminate that self-reactive immune cells. Ways that this can happen is through a sequestered antigen, infectious disease, neoantigen, a new antigen, forbidden clone, defective peripheral tolerance. Some factors associated with this include heredity. Many are associated with the specific HLA antigens. There's also some environmental factors such as maybe a viral infection or chemical exposure or even hormones. There are also immune deficiency disorders that are out there. This is an abnormality in one or more of the branches in our immune system. It may be missing or it may be changed in function. This will lead us to susceptibility to infection or cancer development. Infants start off with passive immunity. Infections begin at about 6 months when this starts to decline. Normal antibody production begins around age 1 to 2. Some of those clinical indicators of immune deficiency include severe and or recurrent infections, so sinusitis, ear infections, otitis media, pneumonia, things like that. They'll also be exposed to what we call opportunistic infections, so things like fungus that would not normally grow in an area on an otherwise healthy person, or invasive fungal infections. Primary immune deficiency are most often congenital and inherited. The types include humoral or B cell deficiency, and it's predominantly antibody deficiencies. There's also cell-mediated or T cell deficiency, or a combined T and B cell deficiency with and without non-immunological abnormalities. You could also be deficient in complement, as well as disorders of phagocytosis. Now, humoral or B cell deficiencies are the most common. This leads to a decrease in that antibody production because remember, B cells produce antibodies. We're going to have increased infections, especially bacterial infections. An example of this could be common variable immune deficiency or deficiency in IgG. You could have selective IgA deficiency or IgG subclass deficiency. Cell-mediated or T cell deficiencies can result in viral, yeast, fungal, and atypical infections. There's also that combined B and T cell deficiency. This is the failure of adaptive or acquired immunity. An example would be a severe combined immunodeficiency disorder. This is a group of disorders, about 20 of them, and its most common form is X-linked. The defects impair B and T cell maturation and receptors. We can also have disorders of the complement system, so we might have a deficiency in a factor such as C3 deficiency, and that can lead to bacterial infections. Disorders of phagocytosis, this will affect our neutrophils and our macrophages. This can be a problem of number, how many we have, or how they work, how they function. People will display signs of recurrent and severe bacterial infections. Now, secondary immune deficiencies mean that they're caused by something else. So extremes of age, very young, very old, stress, cancer, nutritional deficiencies, chronic diseases such as kidney disease, diabetes, GI problems. Medical interventions can lead to immune deficiencies such as chemotherapy, radiation. Acquired infections such as HIV, Epstein-Barr virus, and measles can all lead to the development of an immune deficiency that is caused by something else. We're going to evaluate these patients by looking at their complete blood count so that we can see what their white blood cells look like, their immunoglobulin levels, their B and T lymphocyte cell counts, including the CD4 T helper cell and the CD8 T cytotoxic T cell. So infants have less chemotaxis, so attraction of neutrophils and macrophages to the source of infection. They also have decreased complement response. They get IgG from the mother in utero, most transfers in the last weeks of their pregnancy. They also get immunity through breast milk. They get IgA, complement, macrophages, and lymphocytes. The elderly often have a decrease in the number of alveolar macrophages, so those are macrophages that live in their lungs. They have a decreased number of mast cell degranulation. They have decreased chemotaxis and function of the neutrophils, as well as a decreased number and function of lymphocytes.